Good afternoon. It is truly my honor to be a speaker at your second Vietnam National Children's Hospital Pharmacy Conference. My name is Shao-Chin, and my topic was given by the committee, which is sterile compounding practice in Taiwan. Since we are all from Asia and have pretty much the same Chinese cultural background, I hope what I share with you today should become an encouragement between us. Because we only have 30 minutes, I would like to share the essential concept of sterile compounding and practice, and also how we came to the current status of sterile compounding in Taiwan. Finally, I would like to point out the direction we should go in the near future for Southeast Asian countries. In the Chinese language, the term for sterile product means products without any bugs. That means a product has no bugs. Due to this distorted Chinese term, many healthcare professionals, even pharmacists, have this erroneous concept in Taiwan. I have asked the same question to the pharmacists attending the FAPA GPP program. I found approximately 50% of them have the same problem. Okay, so sterile products contain some microorganisms, but they are so low that the products will not cause any diseases in patients receiving these products. This incorrect concept could lead to two extremes. One extreme is that people believe they cannot reach the standard and they are often anxious and fear using sterile compounded products. On the other extreme, people try their best to purchase expensive equipment and believe that the higher cost of the facilities, the better the sterile quality. I believe that we need to operate sterile product preparation facilities with reasonable costs to reach accessible results. Currently, we have several commonly used international guidelines for sterile compounding, including non-hazardous and hazardous. USP Chapter 797 and Chapter 800 are the two major guidelines in implementing compounding practice and constructing engineering control. For sterile and hazardous compounding, protecting personnel and products are the major concern. 2008 version of the USP 797 and the 2016 version of USP 800 should be the references. For sterile and non-hazardous compounding, protecting the products is the single and most concern. 2008 version of the USP 797 and the 2019 revised version of USP 797 should be consulted. We need to know a little about the story of USP 797 and 800. USP 797 was originally published in 2008 and covered all sterile compounding. I mean hazardous and non-hazardous sterile compounding. The hazardous drug compounding is considered high risk and require a more comprehensive standards. Therefore, USP 800 came up and was published in 2016. And the USP 800 actually include sterile and non-sterile hazardous compounding. Since the sterile hazardous section in USP 797 was moved to USP 800. The 2008 version of USP 797 needed a revision, and therefore its 2019 version came up. Comparing the sterile, hazardous, and non-hazardous compounding, there are similarities and differences. For primary engineering control, hazardous compounding requires biological safety cabinet, which has vertical airflow. But non-hazardous compounding could use a horizontal laminar airflow hood. Both require the air quality of the direct compounding area as ISO 5 level. Considering the secondary engineering control, sterile hazardous compounding requires both anti-area and buffer area, the air quality of ISO 7. But non-hazardous compounding requires the air quality of buffer area is better than that of the anti-area, which is ISO 7 and ISO 8. Because in hazardous compounding, the buffer area has negative pressure and the air flow from anti-area to buffer area. It is necessary to maintain ISO 7 air quality in the buffer area. And the air quality of anti-area must be at least ISO 7. In the non-hazardous compounding, the air flow from the buffer area to the anti-area, which is totally opposite from the hazardous compounding. It is necessary to maintain ISO 7 air quality in the buffer area. And the air quality of the anti-area could be lower level than ISO 7. This table shows you the requirement for sterile hazardous compounding recommended by USP 800. The key concept is sterile hazardous compounding could occur in the best possible facility, which is equipped with ISO 5 biological safety cabinet, plus ISO 7 buffer area and anti-area. The wall between the buffer area and the anti-area is fixed. There should be HEPA filter supply air, 30 air changes per hour, and positive pressure to adjacent area in the anti-area. It also could be done in a facility of lower criteria, in which ISO 5 BSC was placed in an unclassified buffer area, which means the buffer area is not ISO 7. The buffer area must be vented outside, must have 12 air changes per hour, and must be negative pressure to adjacent areas. How could this be? Both conditions are acceptable in USP 800. Before I answer this question, I want to discuss another related concept first. USP 797 categorizes compounded sterile product into 3 risk levels, which are low, medium, and high. Low risk CSP, which is compounded sterile product, is defined as made under ISO 5 condition and involves the aseptic transfer of manufacturer-based sterile products using sterile equipment to compound IV admixtures. Its beyond use date at room temperature is 48 hours. The medium risk CSP is defined as more than 2 additives that are part of the IV admixture, with complex preparation involved. Its BUD at room temperature is 30 hours. The high-risk CSP is defined as the compounding of manufactured ingredients that are non-sterile, performing compounding in conditions outside ISO 5. Its BUD at room temperature is 24 hours. Notice that The CSP made in conditions outside ISO 5 is still considered a sterile product, but has a very short BUD. This table shows you the different BUD according to the air quality and the complexities of manipulation. Low risk level CSP have the longest BUD 48 hours at room temperature, medium risk 30 hours, and high risk 24 hours. Under the condition of refrigeration, low risk 14 days, medium risk 9 days, and high risk 3 days. Back to the previous question. Why does USP 800 allow sterile compounding to occur under an unclassified buffer area? The second column of the table provides the answer to the question already. The product's BUD is only 12 hours. No further use by putting into a refrigerator or freezer. I would like to make a short conclusion for these slides, which is that we could still produce compounded sterile products even though we may not have expensive facilities, as long as the BUD beyond use date is adjusted according to conditions. Now I would like to share the history of non-hazardous drug sterile compounding in Taiwan. Most compounded parenteral nutrition products made in Taiwan are composed of commercial parenteral nutrition admixture and add-on components. Some hospital pharmacies are currently using compounding machine for withdrawing individual ingredients and mixing them together. The compounding of patient-controlled analgesia is currently mainly prepared by anesthetic nursing staff. Both compoundings are regulated by 2014 accreditation standards. Before 2006, nursing staff withdrew concentrated potassium-containing solution and added the required amount into an infusion bag at the bedside. 2006, KFSYCC, which is the hospital I work at, started the preparation of diluted potassium-containing infusion solution due to the requirement from the Joint Commission International. Since 2012, the Good Pharmacy Practice International Training Program was held by FAPA Foundation, in which sterile product preparation was stressed. Some of you might have attended this training. Currently, around 30% of hospital pharmacy is using a machine for making parenteral nutrition mixture. I believe all hospital pharmacies use commercial parenteral nutrition product plus add-on individual ingredients. Centralized compounding for PCA is around 50% of the hospital pharmacies. Only 5% of hospital pharmacies making compounded potassium-containing solutions. Because there are commercial potassium infusion solutions on market. Like many Asian countries, our nursing staff compounded almost 100% of drugs in vials or ampoules. Long before 1990, which was the year that KFSYCC started operating, physicians and nurses were responsible for the sterile hazardous compounding. The first Type 2 biological safety cabinet was purchased by KFSYCC Pharmacy in 1990. Before 2006, all pharmacies sent syringes filled with cytotoxic agent to nursing staff, and then nursing staff inject the drug from the syringes into the infusion bags. In 2006, KFSYCC Pharmacy started sending infusion bags containing cytotoxic agents with primed IV lines to nursing staff. 2010, the first Taiwan Hazardous Drug Handling Guideline was published by Taiwan Society of Health System Pharmacists. 2011, two closed system drug transfer device for administration obtained Taiwan National Health Insurance reimbursement. So at this time, almost all the hospital pharmacy making chemotherapeutic agent started to use closed system drug transfer devices. In 2012, KFSYCC started using closed system drug transfer device for pharmacy, which were not reimbursed by National Health Insurance. Also in 2012, Taiwan Comprehensive Cancer Center accreditation started, in which hazardous drug compounding and administration safety were stressed. After the first version of Taiwan Hazardous Drug Handling Guideline was published in 2010, there are three more revisions in 2013, 2015, and 2020. 2018, the first hazardous compounding certification program was held by National Yangming Jiao Tong University, where I serve as tenure faculty. 2021, Taiwan FDA completed the first version of sterile compounding standards in Taiwan Pharmacopoeia. My reflections on the story, experience, and educational program in Taiwan are as follows. National guideline and accreditation is the most critical step in improving the quality and safety of sterile product compounding in Taiwan. Education on the concept and practice of sterile compounding in pharmacy school and hospital setting is necessary and should be continuous. While considering limited resources critical, use proper primary engineering control, secondary engineering control, and personal protective equipment according to the correct concept of sterility and financial feasibility. Be careful that more expensive is not equal to more effective. For us, the Asian countries, we should establish a national sterile product compounding guideline and define the appropriate standard in your own country according to the correct concept of sterility and your financial and manpower resources. Here I provide several examples. You may not need to build a ISO 7 buffer area to accommodate ISO 5 primary engineering control. An ISO 7 buffer area for hazardous preparation requires an anteroom with relatively positive pressure and HEPA filter air, which is an expensive facility in terms of electricity and maintenance. Since nursing compounding simple vials and ampoules at the bedside is so prevalent, we could have a standard requiring the nurses to follow strict aseptic manipulation with a 12-hour BUD. We could also put down the following standards in the guideline. A hazardous agent containing infusion bags should be primed before sending to the nursing station, even though we do not have closed system drug transfer devices. This way, we still achieve the same protective effect on nursing staff. We could also allow the use of surgical latex gloves without passing ASTM requirements. But we change the outer glove every 30 minutes for sterile hazardous compounding. Until most hospital pharmacies reach the seem to be compromised standards, and affordable facilities are available in our countries, we could raise the standard gradually without sacrificing any safety for our staff and patients. Thank you for your attention. Now I'm willing to entertain any questions and comments. Thank you.